Assalamu alaikum. It's a long gone. I haven't made any video. Today I'd like to discuss about psychiatry. Start with this. I'll talk about some semi-form questions. I'll discuss about the USMLE inner circle psychiatry part and also the first aid part of the psychiatry. Okay, first study something. Ego defense. There are lots of ego defense. I will go through these ego defense questions as step by steps, but read some stuffs like which ego defense is defined as involuntary withholding an idea or feeling from consciousness awareness. It's repression. It's an immature ego defense. Immature defense. Repression. A 20-year-old goes on 20-year-old does not remember going to counseling during his parents' divorce 10 years earlier. So it's repression, which ego defense is defined as largely unconscious assumption of the characteristics, qualities, or traits of another person or group. Its identification, immature defenses. Like resident starts putting his stethoscope in his pocket, like his favorite attending instead of wearing around the neck, like before, which ego defense remaining at a more childish level development fixation that sergeant grows a tantrum in the operating table because the last case ran very late. Which ego defense is defined as separating feelings from ideas and events. This is isolation of effect. This is isolation of effect, immature defense. Describing murder in graphic detail with no emotional response. Describing murder in graphic detail with no emotional response. So these are the uh, key defense mechanism. These are the ego defenses. Okay, now some questions. If I am going to read, our target is starting near about 1 hour, like taking 10-15 questions at a row. Okay. A 14-year-old girl brought to the physician. 14-year-old girl brought to the physician because of poor academic performance. Why? Because of poor academic performance. Since her delivery, relocated to a new town. Since her delivery relocated to a new town 6 months ago, the patient is halfway through the 8th grade and has been earning mostly D's and F's in the school. He's kind of my type of student. So the patient is halfway in the 8th grade and he's earning D's and F's in the school. She's having trouble making friends, especially since she lost her place on the school track team. When she lost her place on the school track team, I want to. When I was in school, I was playing foot. I was playing table tennis, mm, chess, but I would like to play the cricket as well. But I haven't got the chance. In her last school, she earned mostly A's and B's, kinda my type of student, and had many friends. The family moved after a sudden death of the patient's father, as well as a result of motor vehicle collision. So, something major, something bad happens in her life. 14-year-old girl, hmm, thinking about her uh, father's death. It's quite painful actually. The patient had sustained minor injuries that was successfully treated. Since the family moved, since the family moved, she had been moving frequent. She since the family moved, she has been having frequent nightmares and is easily startled and has trouble concentrating. Her mother says that her daughter so seems to be walking around in the cloud much of the time. So her mother knows that he's walking. So this is very concerning. Physical examination shows no abnormality. The patient visits and is somewhat slow to respond to questions. She's oriented to place, time, and purse. She's not in a delirious state. When there is delirium, person of place, time, his orientation is lost. She feels nervous all the time. Okay, what is the problem in her? She's not panicking. So these rules. Sorry, I am having a cough and cold for long, and it's not improving. I haven't. I've taken some drugs, but it doesn't work. Okay, it's not like separation anxiety disorder, separated from her father. It's acute stress disorder, not like 6 months. I think it's in between either adjustment disorder or PTSD. I don't think that it maybe PTSD. Okay, so Alhamdulillah, I'm correct. It's PTSD. Okay, what happens in the in post-traumatic stress disorder, patient experience intrusive memory, hyperarousal evidence, and negative mood or thoughts that endure for longer than 1 month, secondary to a traumatic event, a life-threatening motor vehicle collision of her psychotherapy and antidepressant medication can address PTSD symptoms. So, post traumatic stress disorder is a syndrome of psychological consequence of direct or witnessed exposure to serious physical or sexual violence or trauma. Though some patients recover quickly this traumatic event. So, though some patients recover this traumatic event, mm, to meet the diagnostic criteria of the PTSD, these symptoms must longer than 1 month. So PTSD must be longer than 1 month. PTSD must be longer than one month. This word is very high that PTSD must be longer than for than 1 month. Okay. Hmm. And can cause social occupational dysfunction. Why it is not adjustment disorder. Adjustment disorder refers to the onset of an emotional disturbance within 3 months of an unidentifiable stressor, manifesting as marked distress out of proportion to the stressor, and a significant impairment in the daily functioning. Significant impairing in the daily functioning. By definition, patients with adjustment disorder do not meet the criteria. Patient with uh, patient with adjustment disorder do not meet the criteria of anxiety disorder, as this patient meets the criteria of PTSD. Okay, next question. A 27-year-old woman is brought to the emergency department after cutting her arms superficially with a razor blade. After cutting her arms superficially with a razor blade. On arrival, she appears calm and she is holding a stuffed animal. She says that she cut herself because mm, she wanted to feel something and is unsure if she will be able to stop herself. She will be able to stop herself from doing this again. She says that she sleeps 8 hours of each night and has a good appetite from the ages 10 to 15 years. She was physically and sexually abused by her stepfather. So she was physically abused by her stepfather. She has never had long-term relationship and has been fired from the physical has been fired from the several jobs because of difficulty getting along the supervisors. Her pulse is 80 per minute, respiration is 16 per minute. So everything normal. Physical examination show laceration over both forearm. Neurologic examination shows no abnormal on mental status examination. She denies depressed mood and suicidal ideation, but convinced that she is worthless and deserves to die. So she's worthless. She denies depressed mood or suicidal ideation, but is convinced that she is worthless and deserves to die. Which of the following is the most likely diagnosis? So this patient. So the, hello, hello. So now this patient. Hello. So I'm looking for the answers now. So she's abused by her stepfather and mother on several occasions. She was physically and sexually abused by her stepfather and mother on several occasions. She denies depressed mood, suicidal ideation, but is convinced that she is worthless. She is worthless and deserves to die. 27-year-old woman brought to the emergency department to Warsaw after cutting her arm superficially with a razor blade. On arrival, she appears calm and is holding stuffs, and she appears calm and holding stuffed animal. She says that she cut herself because she wanted to feel something. She will be able to stop herself from doing this again. She says that she sleeps 8 hours. She was physically and sexually abused by. Um, she was long-term relation has been fired from several jobs because of getting along with his supervisors. Getting along with his supervisor, physical examination showed laceration of the both arm. She denies. It's not. She's not malingering. It's not post-traumatic stress disorder. But she's convinced that she's worthless and deserves to die. It's not DID. It's dissociative identity disorder. It's not hypochondriac. It's not. He's not faking. It's not conversion. I think so. It's maybe major. It's not PTSD. It's not malingering. As far I'm concerned, she's not faking. It's not AMDS. It's a borderline personality. I think that she has borderline personality disorder. That is the main thing I'm looking for. Okay, it's a BPD. I'm right. So in borderline personality disorder, what happens in the borderline personality disorder is a cluster B personality disorder, emotional dramatic cluster that features of unstable sense of self, unstable of self, and tumulus relationship likely caused by combination of genetic polymorphism in serotonin dopamine receptor and emotional invalidation or abusive during childhood. Patients with BPD unconsciously learn to make impulsive and dramatic gestures, including self-harm to obtain attention and emotional fulfillment from others as a result of inadequate emotional attunement from the caregiver. Patients with BPD do not learn to label, understand, or regulate their emotions. Their negative emotion experience are so intensely painful that people with BPD must separate um, these experiences from their consciousness. These splitting leads people with BPD to black and white thinking that includes seeing people as well as good or as well or bad. Uh, Black and white thinking back, and these splitting leads because of affective dysfunction Because of effective dysfunction and hypodopaminergic tone, patient may use substance. Patient may use substance or self-harm endorphin, producing endorphin to artificially create a positive effect. Chronic invalidation also leads to poor self-esteem, worthlessness, and the consequent reliance on others for self-esteem needs, resulting in an intense fear of abandonment and severe distress when abandonment happens. The ability to self-soothe and difficulty being alone leads to of the transitional of mm, attachment of the transitional subjects like stuffed animal attachment of the transitional object like stuffed animals. Okay, it's not a hypochondriac. Patient with hypochondriasis or illness anxiety disorder demonstrate persistently excessive anxiety and preoccupation about the possibility they may have serious illness and such and that they perform health related behaviors and exhibit maladaptive avoidance. The patient does not express anxiety about his health. It's the MDD includes 2 or more weeks depressed mood, anhedonia, guilt, feeling of worthlessness, difficulty concentrating, cerebral parts, neurovegetative symptoms, decrease in energy, sleep disturbance, appetite disturbance. Patients with BPD demonstrate affective instability rather than a consistently depressed mood with a neurovegetative state. An 87-year-old man is admitted to the hospital because of dehydration and emaciation. Because of dehydration and emaciation, he appears catatonic and is responsive and is unresponsive to questions. 1 month ago he began withdrawing from relatives. He began withdrawing from relatives and talking constantly about death. He appears catatonic and is unresponsive to question. 1 month ago, he began withdrawing from relatives and talking constantly about death. He gradually stopped eating and drinking and has a 9 kg weight loss during this time. He has a 35-year history of major depressive disorder. He has a 35-year history of major depressive disorder and has attempted suicide twice. He has no chronic medical condition, currently takes medication. He appears cachectic and is starting and staring into the space. He does not respond to verbal stimuli. He does not respond to verbal stimuli. He is 5 feet 6 inches tall, weighs 50 kg, BMI 18 kg per meter square. Examination shows temporal wasting. Examination shows temporal wasting. Which of the following is the next best step? It show dehydration, 87 dehydration appears, catatonic behavior, unresponsive to questions. Hmm, weight loss. He appears cachectic and staring into the space. He does not respond to verbal stimuli. 5 feet 6 inches, BMI 18. Examination shows a temporal wasting. Biofeedback, diazepam therapy, fluoxetine, diazepam, fluoxetine. I think that ECT is the safest for this patient. Okay, catatonia, I got right. Acute catatonia is characterized by mobility, mutism, stupor, staring, and negativism, and is often associated with applying psychiatric or general medical condition. Acute treatment option: benzodiazepine and electroconvulsive therapy. Acute catatonia is a syndrome of severe psychomotor disturbance, classically characterized by immobility, mutism, stupor, staring, and responses absent responses to questions and instruction. Negativism, it is frequently associated with underlying psychiatric or general medical disorder. Delayed diagnosis can lead to poor outcome. The patient displays evidence of severe malnutrition related to catatonia in the setting of major depressive disorder. He should be admitted to the hospital and treated promptly with benzodiazepine or electroconvulsive therapy, fluid resuscitation, electrolyte repletion, and careful monitoring. The lab study for refeeding syndrome should be performed as well. Both benzodiazepine and ECT are considered safe and effective. The major depressive disorder should be initiated. That's it. Okay, 19. A 25-year-old primary gravid woman at 16 weeks of gestation. She is 16th week of gestation. Increase. Okay, 25-year-old primary gravid woman. 25-year-old primary gravid woman 16 weeks of gestation has increased episodes of crying. Difficulty in increased episodes of crying, difficulty in falling asleep, decreased energy, loss of appetite over past 6 weeks. She has a history of recurrent major depressive disorder. Her family is concerned that she might inadvertently harm herself or her fetus. Her husband reports that she has lost interest in daily activities. She starts that she has no suicidal thoughts. She is convinced about her ability to take care. She is her ability to take care of a newborn and is questioning her decision not to terminate. Questioning her decision not to terminate the pregnancy. Which of the following is appropriate next step in the management? She states that she has no suicidal thoughts. She is concerned about her ability. She is concerned about her ability to take care of a newborn, and is questioning her decision not to terminate the pregnancy. Mm, mm, I think then admit the okay explanation of the risk and benefits. So should explain the risk and benefits on antidepressant therapy. The patient whenever NDT or more weeks or all the decrease the patient meets the criteria of the MDD, symptoms of the MDD, 2 or more weeks of depressed mood and hedonia, neurocognitive symptom decrease, energy, sleep disturbance, appetite disturbance. These symptoms disturb everyday functioning. It is recommended that patients with recurrent major depressive disorder are treated with antidepressant and indefinitely in gravit. Patients with moderate to severe depressive symptoms, SSRI, and psychotherapy are generally recommended since the risk of untreated depression, neglect, suicide, infanticide typically outweigh the risk of fatal adverse effects of the antidepressant medication. SSRI are not considered major teratogens, though to third trimester use may lead to mild neonatal adjustment syndrome and real pulmonary hypertension. The newborn in gravid patients with MDD, physicians should discuss about the risks and benefits of the MDTs. Admittedly unnecessary, the patient denies passive or active suicide. So, okay, question 20. A 17-year-old boy is brought to the emergency department uh, by his mother because of 20-minute episodes of several chest pain and sweating that I started sweating that started 1 hour ago. Which he was watching television. On arrival, he is alert and he is alert and repeatedly expresses concern that something is very wrong. He reports that during the episode, his heart was pounding. He felt short. His heart was pounding. He felt short of breath, and he was sure he was having a heart attack and was going to die. Mm, 1 month ago, he had a similar episode concerned 30 minutes ago, and At the time, results. Okay, ECG obtains emergency department showed no abnormalities after the initial episode. He quit the football team and he has continued to limit the physical activity. He is afraid of breathing. On another episode, he reports that no insomnia. Mm, mm, A 17-year-old girl is brought to the emergency department by his mother because of her 20-minute episode of severe chest pain and was sweating that started 1 hour ago while he was watching television. On arrival, he is alert and repeatedly expressed concern that something is wrong. He reported that during the episode his heart was pounding. During the episode his heart was pounding. He fell short of breath. He was sure that he was going to die. 1 month ago, he was similar episode that occurred in the evening, and message of 10 emergency revenue showed no improvement after the initial episode. He quit involving the festival. He I think he's panicking. It's panic disorder. I'm sure about. Okay, this is panic. Uh, we can use short-term benzodiazepine or SSRI, long-term short-term benzo, long-term SSRI. That is the main thing. So panic disorder features panic attack that occur unexpectedly and are associated with changes in the behavior to avoid panic attack triggers. The patient has likely experiencing panic attack with panic disorder features acute fear or anxiety that peaks with minutes and is associated for additional symptoms, mental state. These symptoms include heart palpitation, tachycardia, with chest pain, dizziness, and sensation of choking, GIA distress, and paresthesia, swelling, chills, trembling, deregulation, the fear of dying or fear of losing control. Hmm. Psychotherapy, long-term SSRI, and short-term benzos. Okay, that's it. Hope you enjoyed.